Welcome to the APAP podcast. Today we are going to be talking about everything you need to know about COPD patients and managing them in your practice. Today I'm joined by Alanna Kavanaugh. She is a board-certified family nurse practitioner. She received her master's degree from the College of Mount St. Vincent in New York. She's currently pursuing her doctorate at Columbia University. Alanna is a graduate program chair and director of the Family Nurse Practitioner program at her alma mater, the College of Mount St. Vincent. Under her leadership, she has increased revenue to $1.4 million annually and restructured the curriculum to improve student outcomes. So she's very passionate about education and does a great job educating about COPD, which is why we have her on today. Her work also improved board certification rates above 88% for the first-time test takers. Clinically, she's worked at New York Presbyterian, Cornell for 18 years in cardiac ICU, pulmonary critical care division as a nurse practitioner, and as a nurse practitioner in pulmonary, right? You've made clinical improvements to include working with oxygen therapy with patients, education programs for patients, support group work, and you continue to work on those programs with your patients in your clinic, right? She also works very closely with the American Lung Association and COPD advisory boards and consults for Weill Cornell on difficult or high-profile pulmonary cases. Alanna received grant funding for $50,000 to support a student-led patient education outreach program. She developed educational materials for patient use on pulmonary drug therapies and protocols, airway clearance, and invasive pulmonary procedures. She's on the board of Region 6 of the NPA and president of her local Sigma Theta Tau chapter. So thank you, Alanna, for being here. I appreciate you bringing all of your knowledge with you today to talk about these patients.
Great. Thank you. Thanks for having me.
Absolutely. All right. So if you were to go back and talk to yourself as a new nurse practitioner dealing with COPD patients, what would you say are the biggest things that you should focus on when you're seeing a COPD patient?
So the first thing I would say is really learn the disease. So I think, we learn what we learn in school, which, I am completely a part of and in that world still. But it's really just the iceberg of what you need to know about managing and treating this disease. So I would say the first thing is to go back, learn the disease, learn the treatment, learn the tools and resources that are out there for you. A big resource for me was really getting to talk to people, not just my patients, but also people who are in the field. And so, talking to the drug reps, talking about the medications, trying to get patient education and all those pamphlets that they make that are beautiful, read them from cover to cover, because there are such great information in there. And it's not just for the patients, it's for the providers as well. So I would say the first thing I would do is really immerse yourself in that role and in that disease. So really learning what the disease is about, learning the treatment, and making connections within the field is really where I would start. I would say my next thing is looking at the resources and really trying to digest them. So I would say it took me 4 to 6 months before I truly understood all of the different inhalers and all the different therapies and how they really worked. And, you really want to become good at that, because it's not just like throwing spaghetti at the wall, right? It doesn't always stick. And so you really want to make sure you're picking the right drug for the right patient and that it's actually getting to where it needs to go. Otherwise, it is like throwing spaghetti at the wall. So you really want to make it personalized. And, we talk a lot about precision medicine, but this is exactly what that is. Making sure that what you've chosen is, the patient can get it, right? That it actually works, and that the patient is finding some benefit from its use. So you may think it's the best thing ever, but the patient is saying, it's really not working for me. And so also listening to your patient is really quite important. So
I love the, I think it's the Asthma and Allergy Network inhaler graphic. Yes, she's showing it right now.
Yes.
They update that every couple years because there's so many inhalers, and I'm going to age myself, but when I started in pulmonary disease, we had like 4 inhalers.
Oh my goodness.
Yeah. And now there are so many, including generics for the first time ever. So that allergy and asthma network sheet is great, not only for your patients, because sometimes they're like, I'm on the red inhaler, and you're like, oh God, what red
Which one?
inhaler is that? And you can pull that out and show it to them, and they can point to the one that they believe they're taking. But also, I found it to be an amazing resource for my new APPs in the practice, because I was like, this is what you need to memorize for classes of drugs. And then
Yes.
what combination do you put those classes in? And, it's a great visualization of all the llamas in one category, all the LABAs, all the combination therapies, all the, and now the newest version of that even has biologic
Yes.
therapies on there, roflumilast, for COPD exacerbation reduction, all of that. So I can't speak highly enough of, if you're new to inhalers, new to COPD asthma, that is a great resource there. Also, the GOLD guidelines, I think, are great to really give you a blueprint of where to start with your patients. So talk to me a little bit about GOLD and how that plays a role for you or any of your new APPs.
Sure. So I think, gold is fantastic. I was asked to be part of some of the planning process with Gold when they were updating the guidelines in
Ooh, look at you.
2019. Oh, yes, I want
Yeah.
to say it was 2019. It was pre-COVID, before the world changed. But it was great. It was a great experience. I would say there's a lot online from them as an organization. It's a really thick packet, but they also have slides. So if you're more of a visual person and you need those slides, they have beautifully written slides that you can use and really read through, and really connect them back to, they source everything in sight. So you can really go back and look and read about more information about different things. The GOLD criteria guidelines, for me, it's kind of the way to go. It's really easy to understand. I think they put it together in a well-defined way that you can follow it. And so it's not complex, even though, a lot of people, when they first look at those numbers and ABC and what does this mean, you need someone to explain it to you. But once you have someone explaining it to you that knows it, it becomes very easy to understand.
Yeah, it's all about how you learn, right? Are you visual? Are you auditory? Do you need to just sit down and read through it, note taker, dissect it yourself? And there's so many resources out there for GOLD. I mean, there's podcasts, there's webinars, there's, a lot of documentation. Do you ever use anything from the COPD Foundation?
Yes, they have a great website. They have really nice, even patient support there. And so you can join, a remote support group, that kind of stuff. It's really, really nice. I've actually attended a few of those because they're wonderful. And some are more for the provider, some are for the caretaker. So they have different, kind of topics. And so you can go to what interests you. But it's a really great resource.
Yeah, I like that. I like to send a lot of patients there also. Any other resources that you would recommend?
I would say, as you're kind of getting your feet wet in some of this, maybe 6 months in, I would start to even look at some of the organizations. So I would look at the American Thoracic Society. I'd look at the chest.
Sure.
I'd look at the ERS. And so I would be looking at these things, kind of looking to see, should I maybe go to a conference? And, is that something I want to attend? And looking at the different materials that they put out, because it's all really great information. And I feel like every time I go to one of these things, I learn something, regardless of what's going on. I learn something all the time. And so just immersing yourself in what is out there in that kind of world, and you'll always be appreciative to get that education.
Yeah, and I'm glad you touched on ERS. I think when I was new, if something was published by ERS, I was like, well, does that apply to what we're doing here in the States? Is that something I should spend my time on? But I would say yes, because a lot of ERS statements, are usually collaborated with ATS or CHEST or that type of thing, or end up being guidelines later in the US. So I would, encourage people to, also look at ERS statements. So if you were to give some advice to a new grad seeing a COPD patient in clinic, how would you recommend they approach those patients? Like are the biggest takeaways of like, you need to accomplish at least these things when you see a patient for the first time?
So I would say for the first time, I would want to know, really where they lie, right? Where are they in the gold kind of classifications, right? So are they gold 1, 2, 3, right? See, so do I have spirometry? Do I have any of that data to kind of classify them where they are? The next piece of classification is I would want to know how dyspneic are they, and how many times they've been exacerbating in the last year. So
Uh-huh.
I'd want to either do a CAT, screening tool, or an MMRC, whichever one you prefer, whichever one you like best. I usually use the CAT because Fernando Martinez, who is my chief, really did a lot of work with the CAT. And so I'm kind of prone to that.
Yes.
But we use both in our office. And so what I do is I really just have the patient fill that out while they're in the waiting room. And so, all that kind of information is there waiting for me when I'm ready. And so, you look to see, okay, what's going on with this patient? Where do they fall? How are they feeling? How many times have they exacerbated? How do they feel their life is? Do they feel like they're able to do all the things they want to do, or do they feel limited? And so I think it's really an open and honest conversation about, are we meeting the goals of care for them? Because we want them to be happy, right? And so I think just first of all, having that, knowing, where they are and are they happy, and trying to figure out what is their kind of long-term goals. What do they love to do? And of course I go back to, what do they do for a living? What do they find pleasure in? And so, really trying to find a plan that's holistic and approach them from all different areas.
Yeah, I definitely agree with make sure you have a spirometry, because sometimes when patients have gray hair and they have any history of smoking, they get a diagnosis of COPD, and you may end up really chasing a diagnosis that is not applicable for that patient. And you really want to see, is this really COPD or not? And if it is, what stage do they fall into? Mild, moderate, severe, or very severe? Because that may definitely impact your plan, right? So they have to have spirometry in order to have that diagnosis of COPD. That's a really big one. And I agree also, subjective information first. How are you feeling? What's been happening since last time I saw you? And because exacerbations are what kill these patients and lead to decline in lung function, are you and really getting them to understand what an exacerbation is. They'll say, no, I haven't had any issues, but I had bronchitis 2 months ago, and you're like, that's an exacerbation.
It's an exacerbation, yes.
How do you educate your patients on what an exacerbation is? Because that I find is a struggle, because patients don't understand that if I get bronchitis, it sucks to be me, right? For a couple weeks. If they get bronchitis, they are at a higher risk of, loss of lung function they may not get back, hospitalization, pneumonia, and death, right? Those are not risk factors for non-COPD patients with bronchitis. So how do you educate your patients on exacerbations?
So, the first thing, just like you said, it's like, make sure they understand what that truly means. So do they understand that when they get a cold, that this potentially is actually an exacerbation? So, I kind of, get very close with your patients and say, anything that's going on like that, just call me. Send me an email, call me, let me know what's going on so that we can have a quick conversation on the phone and let's see what's going on. The other thing I say to them is, if your sputum has changed in quality or consistency, then that to me is alarming for an exacerbation. Not everybody gets a fever, right? And so does it look different? Does it feel different to you? And, do you feel like you're bringing up something that is different than before? And so, making the patient more aware that, maybe it's not just hanging out with the grandkids. Maybe it is actually something that triggered an exacerbation. It could just start like that, but then it goes into something else. And so having a really good connection with your patients and making sure that they have access to you, I think is really important. I give a lot of people my email from work, and I'm on it constantly, even on the weekends. And, it's just a quick phone call, just checking in. How are they doing? If you're lucky enough to have a triage nurse, good for you. But if not, just a quick, how you doing? I noticed, you sent over a message, tell me a little bit more about it.
Yeah. They really struggle, sometimes with not wanting to bother you, right? And I'll tell them, I'd rather you call me and it be nothing versus it be something and not, be able to catch that very early. I also tell them, COPD, you have good and bad days. And that's just very normal, this up and down, good and bad days. But 3 bad days in a row is probably something else. And I'd like you to be calling me, or if it's a weekend or holiday or something, urgent care, or, whenever, that type of thing is. And if you have patients who are very astute to their exacerbations, they know when they're having them, they see you appropriately, call you appropriately, or have them frequently. I know that a lot of times I will, if it's a patient I trust that has that acuity, I will give them antibiotics and prednisone to keep at home to start as soon as they start having symptoms of an exacerbation. And then the rule is, if you take it, you have to call me so that I can document it, because I want to know how many we're having in a year or in 6 months. And then I can refill it for you so you have it at home again. I don't personally like to give them refills on their antibiotics and prednisone to keep at home, just because I feel like sometimes I'll see them, you'll lose them to follow-up for whatever reason. They come back and they've refilled it 7 times in 3 months. And you're like, what? What is going on? Yes. So that's what I do. Do you do anything similar for your patients?
Yes, I do exactly the same thing. And it really works well for the patients that you trust. Like you said, you don't want to just go and give it to anybody. But if you have this really good relationship and they can notice when they're triggering their exacerbations, that they can kind of be, a conduit and a helpful person in their care.
Yes.
And again, just like you said, documenting, figuring out how many times, because it can mean that they're progressing. And so
right.
You want to capture that data to find out, what's going on. The other thing I didn't bring up that we should definitely highlight is making sure that they're having the proper vaccinations and
yes.
All of that, especially pertussis. And, we saw a ton of RSV this year. So making sure that they're well vaccinated and keeping on top of that, as well as, of course, the hand washing and the mask wearing and things like that.
Yeah.
But
yeah,
just to keep that.
Tracking those exacerbations, other than documentation, the biggest reason is because now you can advance them up the GOLD protocol of therapy and everything else that you can do for exacerbation reduction. And like you said, vaccinations, maybe get them into pulmonary rehab, maybe, those types of things. Speaking of pulmonary rehab, when do you start talking to your patients about pulmonary rehab?
Like right at the beginning, to be honest, because I want them to not only think of it as something they do when they're old and sick, but it's to me, it's exercise. It's really making sure that you're strengthening the muscles within the chest that will kind of help their ability to kind of stretch and need more oxygen, right? So I think of it as increasing the space in the intercostal areas, right? Like they're really expanding that area there and really strengthening those muscles, because they get such muscle weakness and fatigue from continuously being sick, if that's kind of the path that happens. So I always say early, even as soon as they get the diagnosis, they don't have to go to rehab, but there are certain exercises, lung exercises, that they can start even at home. And they can do that and continue to do that, and a lot of it's weight bearing and deep breathing, diaphragmatic breathing, things like that. But there are things that don't cost anything and they can do at home, and it'll just make them feel better and hopefully give them a kind of a leg up when they do have an exacerbation, so that they're not, as sick, so that they're having some exercise and capability of withstanding an exacerbation.
And there's so much data out there about survival and outcomes in COPD patients who are aerobically active. And if they can't get to pulmonary rehab or that sort of thing, that's definitely something I talk to them about, doing at home, what they can do at home. I love to compare patients to cars. A lot of times I feel like that analogy they get. And I'll say, it's like if your car's very inefficient, it's going to go through a lot more gas. Right? If it's really tuned up, it's going to be efficient and work a lot better. And you've got a problem with your engine, and so we need it to be, as tuned up as possible, that type of thing. So I like to use that with them. So back to our checklist of seeing a patient, we're asking them about symptoms, exacerbations, making sure they understand what that is. We've got the right diagnosis. We've got right staging. Is there anything else that you like to accomplish during your visits with your COPD patients?
I would say that's kind of the big things. And then of course, the vaccinations, lifestyle, what do they see themselves doing? How do they feel limited? And really having those kind of long-term conversations, or at least starting to think about them, I think is helpful, because it's, if somebody was a dancer their whole life and all they want to do is dance, then I think setting that as, okay, well, we're going to start, breathing exercises, then we're going to start pulmonary rehab, and then we're going to try to move towards that, maybe in a chair rather than standing up, right? But we may move towards that goal. And so trying to kind of personalize it for that patient, I think is really helpful.
Yeah.
I think you covered everything. I don't know. You tell me.
Yeah, it's a lot. I mean, when you get in the room with them, sometimes you get very overwhelmed by issues they're having with their DME company for their oxygen, or they're having with their inhalers, or depression, is a big thing for them with any chronic disease state, and giving up their independence and things that they were once able to do and now they can't. I think the only other thing, is just to see when their last spirometry was. I like to really trend that. And I tell them, it also goes up and down, just like with COPD symptoms, daily symptoms that they have. But I like to trend it because it kind of gives us an idea of how fast we're going or how slow we're going. I think sometimes that helps with your smokers too, if they're still actively smoking, just to kind of see their trend. Some patients, they see that decline, and I feel like that sometimes helps them understand the impact their smoking's having kind of in real time, type thing. But yeah, I would say those are probably the biggest ones. What would you say are your biggest challenges when you're in a room with the COPD patients? What are common things that they're going to come up with that you need to help them with problem solving?
Okay, so I think some of the things you highlighted are spot on, right? So oxygen is a big one. The DME company, what can they get? They want this and they need this and
Right.
whatever it is, right? So there's that, which, sometimes I could have a whole different visit that's specifically about oxygen, and that you can kind of bill and code specifically about education and oxygen, because you really can have a whole visit about that. Then the other things are, like you said, the inhalers. And I try, because this is best practice, but I try to have them bring their inhalers in, show me what you're doing. I want to see if you're doing it the right way. And is this working, right? Is this inhaler working for you? And trying to figure out, is this the right thing? And, like you said, insurance coverage, really big deal with insurance. Oh, yes, I had this one, but they changed me to this one and they said it's the same. And I'm like, it may be the same drug, but it's a different delivery method, which is different for you. And so knowing, is it the powder? Is it the spray? Those things really make a difference. And so I need to know that information. And so asking them to bring it in with them and demonstrate it in front of me, I think that really helps kind of close that loop for me. And so, yeah, I would say those are kind of the two biggest ones. And then the exacerbations, I think, is the other big thing, making sure truly to, identify what an exacerbation looks like, give them kind of your emergency medication treatment plan, and then making sure they call you and follow up. I would say those are the kind of the big things that I'm dealing with. And then, of course, smoking cessation, and then vaccinations, and pulmonary rehab. Those are the others.
Yeah. The inhaler instructions you can bill for. I think it's like $18 or something like that. But, they add up. If you're talking to your patients about inhalers, you're demonstrating how they should be doing it. And you can get demos from the drug reps. You can, if you're...
have some hypnic.
Yeah, exactly. If you're lucky enough to have reps that are allowed to come to your facility, definitely ask them for demos. You might even be able to order them online, but it's great for, if you have enough demos, the patient can demo there in their office, but I usually demo myself, doing it if they don't bring their medication or that type of thing. But you can bill for that too. And then back to the DME issues with their oxygen devices, with their ventilators, if you're going to put them on home ventilators or portable ventilators. A lot of times your DME company will also give you demos for the office to show them. And they're a great resource too, I think, to say, like, can you give me your company's policy for what I need to document for certain things. And they're usually really quick to do that, because the better your documentation is, the easier it is for them to fulfill those orders for patients as well. So make friends with your DME, if you can, because they can be a really great resource. Speaking of ventilators, so when do you start talking to your patient about ventilators, or do you use ventilators in your practice?
We do. We do use them quite a bit. And it's, mostly for the nocturnal, like when they're sleeping. That's really when we're seeing a big, non-invasive ventilation for sleeping. And typically it's paired with, you have like a sleep study, and then there's some kind of crossover there where that they're hypoventilating during sleep. And so that it would kind of benefit them to be on nighttime ventilation that is not just, CPAP driven. So, we kind of talk about it, to be honest, kind of early, just because I think, once they really have the diagnosis of COPD and you're managing that, I don't think it hurts to get a sleep study, because we know these people hypoventilate. And so, I always think of like brain oxygen. I'm like, oh, especially if I feel fatigue or I feel unclear. And I'm like, I would love to know how your sleeping is. Right. And so, so I think, getting an overnight sleep study, trying to see kind of, do they meet the criteria for that? And if they don't, just keeping it in your records, right? Like, okay, we tested on this date, maybe in a year again, or whenever they say they have more symptoms, we can kind of look at this again. We'll reapproach this. And I like the NIVs better, just because you can feel like you can more customize the volumes and the pressures and all the things that other people have trouble with CPAP. You can kind of customize that a little bit better with the NIVs.
Yeah.
So,
yeah, the patients, I'm at a really high elevation. Our clinic's, over 6,000 feet in elevation, and patients get breathless here very early in the disease than they did when I worked at sea level. At sea level, I'd have to argue with the patient that they had COPD if their FEV1 was like in the 60s or 70s. They're like, I'm fine. I don't have COPD. And here, they'll be in the 70s and they're like, I'm dying. I can't breathe, So I don't have to argue with them as much. But definitely those severe and very severe patients, we have a lot of hypoxia here, a lot of hypercapnia. And especially if your patient's ever been admitted for hypercapnia, those are great patients to maybe talk about. This is almost like a breathing treatment. You wear it for 30 minutes to an hour a couple times during the day. You sleep with it at night. It helps get your CO2 down, and what that means and how they may feel. If they're having bad days, wildfires or weather changes or whatever, this is something they could sit on during the day, and maybe keep them out of the hospital, especially if they're frequent, hospital, visit patients. I love those. And lately, I have been a huge fan. I'm not sponsored by Life 2000, but I've been a huge fan of the Life 2000 portable ventilator. I don't know if you've seen it, but it's the size of like an old-fashioned remote control. Clips on them like a fanny pack. They still have to wear oxygen. They have to use tanks. They can't use portable concentrators. But we actually got the rep to give us a demo for the office. And I'll have patients walk up and down the hall with it and just see what they think. And if they think this is something that would help them be mobile, because I have so many patients that come in wheelchairs and it's because they're too dyspneic to do anything. They're showing up late to their appointments because it's taken them 3 hours just to get dressed and to get there, because they're so breathless. I think those are great devices for those patients that are pretty severe and their dyspnea is now, impacting their performance. I really like those ones. And I think there's a couple other portable ones out there, but I'm just not as familiar with them. But again, get with your Hillrom rep or whoever else, and they're great at showing you what those devices can do, and could probably get them for your office also for patients to try out. Yeah. So speaking of those like severe, very severe patients, when do you start talking palliative care and hospice with your patients?
So I think, knowing from the beginning about them, a more holistic approach to how they envision this disease, how they envision death and dying, right? I think knowing that from the beginning is helpful, because, you want to know, do they want to do everything possible to kind of live, more, right? So I have some people that are like, my daughter's getting married, I'm having a grandkid, I want to do everything I can until you say I can't do anymore, right? And then you have people on the other spectrum that are like, I don't want all these tubes, I don't want oxygen, I don't want to deal with those types of things. And so you really have to kind of know your patient, kind of see where they are. I would say, we've seen some great things with the valves, and the use of the valves and in not only preserving function, but also gaining, right? Giving them more ability, more function. I think hospice is, kind of, really just knowing when it is appropriate to bring that up, kind of looking at the patient's goals and what they want. And even transplant, and so for us, transplant is an early thing, right? So we do that early. Like we see this person is a chronic exacerbator. We see them kind of going down in their lung function. We're thinking transplant, if that's really what that patient is going for, we're thinking that early. So I feel like even though these conversations are hard, you kind of have to have them somewhat in the beginning of the disease to kind of lay the groundwork for these are the possibilities and this is what's out there. And so then you can say, this will take you time to get used to. And you may not say to me tomorrow, hey, I want you to put me on that oxygen thing and we're just going to walk around and we're going to be okay. And it takes time to cope and get through these things. But knowing what the options are very helpful. And I think it takes multiple visits to do that. Yeah. It's not just one visit.
I agree. Having that conversation before they need to have it makes it so much easier to have that conversation when you have to have it. So definitely that, is it quality or is it quantity or is it something in between? What is the most important to you? Or do you want all the poking and prodding and procedures and lung function testing and, to get you as much quantity of time here, or is it really quality focused, everything I could do to help your symptoms? And yeah, at the times that I've had that conversation early with patients and then, got to follow them later and say, okay, last time, we talked about this, quality was really your goal. Is that still your goal? And you're really suffering despite our maximum efforts. Let's talk about other things we can do to make you comfortable. It doesn't take them by surprise, I think, as quickly. Right. And same with the patients that you're talking about transplant. You wanted to be as aggressive as possible. Do you still want to be as aggressive as possible? You've aged out of the transplant service, but we can offer you pulmonary valves. We can talk about lung volume reduction. We can talk about other things like that. Yeah, it definitely. Right. Sets it up to be an easier conversation later if you have it earlier with patients, for sure.
And I would definitely say it's something you mentioned, but checking back, because people's mind do change. I think at one point they're like, yes, do everything possible. And then you kind of circle back and they're like, this is not the quality of life I want to live. And so I think I think you did a really nice job there saying quality over quantity or both, right? And so trying to kind of find where they are, but then also readdressing it at what you need to and kind of saying, are we still in the same place? Are we still where we want to be? Are you feeling comfortable with this plan? I think that's really important. So,
yep. How often do you follow your COPD patients? How often are you seeing them in clinic?
I would say, of course, anytime they exacerbate, they'll call. So we want to know for sure about exacerbations. But if they're well and everything's good, I would say every 3 to 6 months, depending on what's going on. So,
same.
I think COVID put us through a loop. A lot of people did not come in. It was everybody kind of stayed home and really hibernated, wore the mask. And people are still wearing the mask and things like that, which, we can't complain because it's keeping us, keeping our patients a little safer, right? And I think people got additional years because of those drastic lifestyle measures. But, I think 3 to 6 months is kind of the sweet spot of just checking in, seeing how they're doing. We would probably redo some spirometry in 6 months. We usually do 6 months to a year, depending on what's going on with their lung function. And like you said, to try to find out, are they kind of really going downhill and quick, or is it really kind of, they're just steady. They're just really, really steady. And so knowing that about your patient as well is really helpful. I also, I'd be remiss not to also add the alpha-1 testing and making sure that that's part of your initial kind of workup for a patient, especially if they're very young, but not necessarily if they're very young, right? Like don't just dismiss that, because I always think it's an opportunity to totally change that person's lifestyle if you actually find, if you find the zygotes that are exactly the same, right? So, you can really change someone's outlook if you find that, although it's obviously rare.
Oh yeah, absolutely. All right, well, Alanna, I appreciate you coming on today. You have shared a lot of information. I think that definitely APPs new to COPD patients, new to pulmonary, or even, maybe those that just are seeing more COPD patients in their practice are going to learn so much. Thank you for being on today, and thank you all for listening, and please subscribe to the podcast. It's the best way to support APAP for you guys to do it that way, and we will talk to you next time.
Thank you.